Welcome to our telehealth interview series. This is Shannon Sullivan from Vision 2020 USA. For this installment, we are honored to speak with Dr. Usha Kim, Dr. R. Kim, and Mr. Thulasiraj Ravilla of Aravind Eye Care System. The interview is hosted by Dr. Mitchell Brinks, the chair of Vision 2020 USA. Dr. Usha Kim is the chief of Orbit, Oculoplasty, and Ocular Oncology Service, and the director of mid-level ophthalmic personnel at Aravind Eye Hospitals. In 1998, Dr. Usha started the Department of Orbit and Oculoplasty at Aravind Eye Hospital. Under her leadership, this department has become a center of excellence in the treatment of the rarer ocular conditions that have to do with trauma, congenital anomalies, and cancers of the eye, as well as one of the leading units for diagnosis, treatment, rehabilitation, and research in this field of ophthalmology. Dr. Usha set up the Ring of Hope initiative in 2004 to raise funds for the treatment of eye cancers free of cost to patients who need it. Her unit is also a preferred destination for training in orbit and oculoplasty and has hosted ophthalmologists for long-term fellowship as well as international fellows for short-term training and ocularists from across the globe to train in producing custom-made ocular prosthetics. Dr. Usha is the president of the Oculoplastics Association of India. We also interviewed Dr. R. Kim, Chief Medical Officer at Aravind Eye Hospitals. He is also the Senior Medical Consultant, Retina and Vitreous Services, and Director of Information Technology and Systems. Dr. R. Kim began his career as consultant in vitreous retina services at Aravind Eye Hospital, Madurai, and later became the chief of the clinic. He is the director of Aravind's telemedicine network and IT services. He is also the chief medical officer of Aravind Eye Hospital, Madurai. Mr. Thulasiraj Ravilla is our third guest and is the director of operations for Aravind Eye Care System and the executive director of the Lions Aravind Institute of Community Ophthalmology. Thulasiraj is one of the founding members of Aravind Eye Care System, and he became the administrator of Aravind Eye Hospital in 1981. He is also the founder-president of Vision 2020, the Right to Sight India, and is now an honorary member of the management board. He is also a board member of the Acumen Fund and Aravind Eye Foundation in the U.S., the Indian Institute of Health Management Research in Bangalore, and president for Auralab Trust. He has been on the board of Siva Foundation, the Indian Institute of Management in Kolkata, and trustee and treasurer for the Development of Humane Action Foundation. He has been a member of several national and international advisory committees on eye care.
Thank you again all for joining us here this evening in the U.S., morning in India. And we're very grateful for your time and for your willingness to share your expertise regarding the growth and development of your telehealth system there, your teleophthalmology system. And so on behalf of Vision 2020, I'd like to ask you a series of questions to include your expertise in the larger dialogue we're having on the topic. And so to get us started, I'd like to kind of go back to the early days of your program and ask you what it was that motivated you to think about and start developing a teleophthalmology system. What patient care challenges were you facing that made teleophthalmology seem like a good solution?
So at the core of it, really, if I go to the real core, the driver was really quality and equity in care. So a bit of a background. So as an institution, our purpose was defined as eliminating needless blindness, which really meant that we really would have to bring everyone in need of eye care into our fold, into the eye care fold. And the only strategy that we had, other than having hospitals, was to do outreach, what we call as eye camps. And so at some point, we wanted to do a reality check to see if these eye camps are doing their work in terms of reaching everyone. So we did a formal study, wherein we went back to communities where eye camps were held and then found out everybody who themselves felt they had an eye care problem. And out of that cohort, how many actually attended the eye camp? And that was a dismal 6.75%. It was far below. We knew it was not 100%, but we didn't bargain for less than a 7%. So we recognized that we need to do something different. And then what dawned on us in hindsight was that because these eye camps are held once in a year, normally at our convenience, we felt that maybe if you're able to offer this round the year, every day, that might help, to increase access. So we kind of conceived of establishing, what is now come to be known as vision centers, covering roughly the population of an ICAM, which is about 10 kilometers radius. And so while that was fine, we were kind of pulled back by the leadership of the system, saying that it was clear that doctors won't be manning those. We just didn't have enough doctors, nor would there be willingness with ophthalmologists to go and work in those remote areas. So which meant that we had to rely on a technician, a well-trained technician. But still the lingering question was, will the quality be comparable to what an ophthalmologist can give? And then we didn't feel justification saying that we are okay with the second grade quality because we can't use ophthalmologists. So that's when we started experimenting a lot with, can we use technology to bridge this gap? And then it really took us about 4 years, before we could come up with a solution wherein we could actually put in a very functional telemedicine application. So that really was the motivation and the background.
Another, to just add to what Tulsi said, at the same time, the internet was just coming in and getting available. And there were some experiments in the villages where people were putting these, what they call as internet kiosks, where people could go in and, work on just whatever they need to access. It was a new concept. So I think we thought at that point of time, how do we use this in the villages if we could hitchhike with them? Asking those internet kiosk operators, if a patient comes, can you connect to Aravind and, get an opinion? But somehow, obviously, it was not the right way to do it. So that's what, when Tulsi was mentioning, we were doing with a lot of experiments in technology and finally ended up with a different, what we are having currently right now.
Yeah, so this was in the time period 2000 to 2004, just to give a time context.
So quite a while ago. So as you begin to construct the system, thinking about the building blocks of the system, I guess one question would be, how did you prioritize or select which sites you would set up vision care centers at? Was there a certain distance or community type? What did you think about when you identified sites to work in?
Yeah, we needed to have a place which did not have any ophthalmologists. There should be no access for the patients. And we also realized that we needed to also have a connectivity to the base hospital, which is not too far away, which meant that we could have the supply chain in place and also have replacements for the technicians, which could be supported from the base hospital. So the idea was to have a center positioned in a place where you could have some transport facilities, one, and then you could also have a place where there are no ophthalmologists available in and around, and where again the HR was the main point, where we had HR located in the local villages. Mostly all of these centers were positioned in villages where hospitals were not found in and around that place. So that was how we identified villages.
Yeah. So we are really kind of filling a gap, a void in eye care. So typically in those places, there is not even an optical shop, maybe in a 30-40 mile radius. So, yeah, and we chose places which are sort of natural local hubs, rural areas, wherein people would come from the neighboring villages. They would come there for selling or buying produce and which meant there was some kind of a traffic pre-existing. So which meant they are familiar with that place, and there is some communication that would be there. So that's how we kind of micro-selected the locations.
Interesting. And how many locations did you have, say, 2 or 3 years into the program? How rapidly did the number of locations build over the 20-some years since you started this?
I think it kind of grew in. I think initially we had 5. The first lot was 5. To some extent, I think as this concept was becoming known, there were people keen to fund this. And so how much fund we sought kind of took into account our own bandwidth. So we started with 5, and then we got a grant for 20 from one foundation. So in the next 2 or 3 years, it became 25, and so on. And today we are at about 90 vision centers.
No, there were other factors which also, like as Tulsi was mentioning, one is the HR, availability of HR and availability of the locations with the criteria that we had. Those were also considerations when we were looking for scaling up the vision centers.
And that seems like might be a significant challenge, even at the start of the program, is the technicians to work at the vision care centers. I mean, there's this ophthalmology tier of the workforce, and maybe optometrists and people working in the hospitals. But what was the process to develop this professional and effective team of vision technicians to work at those vision care centers?
Yeah, so the technicians, initially, yes, I think I'll add a point also. We were also in the process of understanding how this would work, and then also look at the success and scale up. That was the thought process earlier on. And at that point of time, we did not consciously choose technicians in the areas from which we intended to develop the vision centers. Eventually, we started realizing that these were the areas. So we set a calendar and started looking out for people. So for a person to blossom out to work in a vision center, we thought we would need at least a good 2 years basic training at the hospital level, and about a year or 2 at the base hospital. And eventually, with a special training, would set out into the village to work as a technician, unsupervised. So this was how they evolved to fit into a vision center. So basically, it spanned out to be 5 years at the base hospital, and eventually set out to work independently at the vision center after 5 years of being at the base hospital. But we are kind of, condensing it a little more. Now we could start off even at, say, 3 years at the base hospital level, which is what we are aiming at. And probably 5 or 10 years later, we would see that we could have a crash course, which could even condense a lot more and eventually put them to task in the vision centers. This is how we've evolved with technicians.
Yeah. And it sounds like you've identified some advantages to find the technicians from the areas where they'll work. What are the advantages of training technicians from those communities where they'll eventually work in the vision center?
Well, what we see is a lot, actually, because they are accepted by the community very easily, and they feel one among the people in the village. So they are ready to interact with them at any level. Sometimes it's not just the eye care. There are so many other added advantages of having these girls from the community, because they seem to be gelling well with the people in the community. And also they seek other help in terms of healthcare as well. So they kind of network with the people, and they associate very well. And they own the village, and the villages own the vision center. So it's like a win-win for both parties.
Yeah, and few other in this. So the attrition rates are very low, because they're all local. It's a reasonably well-paid job and tremendous prestige within the community. And the other one is that because they are part of the community, they have a lot in stake to give the best. So their reputation is at stake as much as Arvind's reputation. So they really give their best in their work. I mean, all this is not planned, but I think that's how the dynamics work out. So commuting every day takes a big toll. If they're not local, in some centers we still have these technicians commuting, and that's quite stressful. To make sometimes to each way 1 or 1.5 hour journey, multiple buses and things like that. It can be quite stressful.
Well, it's a very thoughtful design. As you have expanded the program, and it sounds like the technicians play a role in this, but one question we had was, what has been the community or patient perspective of these vision care centers and getting some eye health through them? Has that been a difficult challenge, and what solutions have you come up with to recruit patients and build confidence among the patients or the community in the vision care centers?
So it is very, the response, personally took me by surprise quite a lot. Now, because we always thought the patients were not aware of what's good for them. They didn't prioritize eye care. So these are all the perceptions that we had. And that's how we designed the care. We try to do awareness creation, advertising, and all of that stuff. But then what really happened when these vision centers were opened was the tremendous acceptance. We had set a goal that time, for want of any data. We had said that roughly 20% of the general population would have some eye care needs. So we should have in our records, or we should have that many patients registered with the vision centers over a period of time. And that happened so quickly. That happened in about 3 years or so. And then that base kept growing, because we were all completely digital. Because of the telemedicine that we put in right from the beginning, we could keep very good records of who is coming from which villages, and is it from the... So we could really relate to the denominator as well. And second thing was that you have to recognize too, like Kim said, in 2004, internet was just coming out. So technology was very new. And telemedicine was non-existent. I can certainly say we were certainly a pioneer in India. So the apprehension was about adoption of telemedicine by the illiterate rural folk who have not seen anything near to a computer. Closest might have been a television. But then there was zero resistance. Now you would find elderly women, men, who are quite illiterate, nonchalantly talking to the doctor in the screen, explaining their problems, no hesitation. So again, this was a very good lesson to us, that we really dropped the ball in the design of providing eye care. And once so that's why we have been kind of very actively promoting these vision centers as a way of achieving universal eye health.
Over a period of time, we also realized it was not just the poor people who cannot travel were accessing, it was people who can afford also were accessing eye care through these vision centers. That was surprising, because I think the question of time, travel, all that made the difference for those people. And they started trusting what's happening in the vision centers. And so people who own a car, their own vehicle, were even going to the vision centers. That's something was surprising for us.
I would probably attribute that to also the way we also monitored. There was monitoring in terms of looking at how the quality is. So there's a lot of quality check also from the back end to ensure that we don't compromise on the quality. That's another factor probably the people started trusting. Yeah. And they didn't want to spend much time at the base hospital where they would have to wait longer hours. Contrary to that, they would be getting their checks done at the vision center. So that's also probably a...
I would think one underlying design factor was In all over Aravind, we pay a lot of attention to closing the loop. In the sense, when someone comes into the system, it is not just about giving a brilliant diagnosis and the appropriate intervention advice, but also enabling the patient to follow through with whatever was said. Now, because it is the follow through which makes the patient better, not the diagnosis or what treatment is advised. And that follow through, though it is largely in the domain of the patient, we want that considerably. Now, so by monitoring, somebody was not coming to understand what was the barrier. Can we systematically address that? So that helped quite a lot. So a patient walking into the vision center, 85-90% of them could be resolved locally, which means they got a complete investigation, a good diagnosis, their doctor telling the patient what is to be done, the intervention. And then if it was glasses or medicines or whatever, they're all available locally. So within half an hour, 40 minutes, they come in with a problem and they go back with the resolution, which in a few days' time, as they undergo the medication or whatever, resolves the problem. So I think that's another factor which built the trust and the reputation. Like you go there, you'll become better.
And so how do you ensure the accuracy of the diagnosis and management? It said you did quite a bit of monitoring to make sure the diagnoses were accurate and people were getting to treatment. Were those kind of scholarly or academic evaluations or an ongoing program or something you do every few years? Or how do you do your quality monitoring of the program?
Yeah, so as far as the technicians were concerned, this continuous monitoring is, we had both the, recertifying them. The process would be yearly, sometimes 6 monthly as well. So we had a direct check on them, testing them and certifying them. That was going on every year. And we would also look at all the parameters which were specified in the records, and we would verify it at the back end. And there's a constant monitoring, like there would be physicians visiting each of these vision centers with a team of members who would look at all aspects of the functioning of the vision center. That would be a monitoring feature which happened every month. And eventually we do a random check on the diagnosis as well. And we also have a process where a diagnosis is made at the vision center and referred to the base hospital. We would verify if the diagnosis made at the vision center and the base hospital are one and the same. So this gave us an idea largely as to whether we are on the right track or not. And if there's any deficiency, we would bring those technicians back and train them at the base hospital and deploy them eventually. So this is a constant feature that's been happening.
Yeah. So I think what is not mentioned in this conversation is that the foundation for telemedicine is an electronic medical record. So the entire record keeping is digital right from the beginning, and it's in the cloud, private cloud. That language didn't exist in 2004. So that there can be simultaneous collaboration between the doctor in the base hospital and the vision center technician in the remote villages. So that was, and then the second part is that all of medicine is protocol driven, right? So, and the protocol, of course, keeps evolving, but at any given point, you do have a protocol. And then the dots that connected are that if you follow the protocol, you would have good quality or good outcomes. So because all information is digital in the electronic medical record, we're able to very tightly monitor the protocol. Like, for instance, we would say anybody above 40 coming for the first time should have intraocular pressure measured. No, or any diabetic that you discover, fundus imaging should be done, and all those can be very easily monitored. No, and we do benchmarking and kind of reflect back to the vision centers. No, and sometimes there are genuine technical issues which can get resolved, and there are also behavior issues amongst the technicians. Some people just don't do it, no, so they will need to be coached and helped. So that's kind of an ongoing journey.
That sounds very thorough. Yeah, very impressive. When the patients do eventually come to the base hospital, have you noticed the vision care centers influencing the volume of like surgical patients for cataract or retina or glaucoma in the hospital? Has it driven patients into care? Have you seen a change in those numbers?
Yeah, but like if you just to throw last year numbers, last year, the pre-COVID year, last year was, most of it is closed. So the pre-COVID year, we had about 700,000 consultations over the year, across that time we had about 75 vision centers. And of that, we had about 25,000 cataract surgeries done, which got referred. So that was a significant number. And then probably another 30,000 patients were referred and seen in the hospital for different conditions. Could have been glaucoma, diabetic retinopathy, uveitis, anything that couldn't be decisively diagnosed or managed at the vision center. So there is a significant addition of that happening. And then today, my guess is that we are covering through these vision centers about 7 to 7.5 million population. Yeah, and for that population, we can quite confidently say we are providing meeting all their eye care needs.
That's incredible.
Another important factor in this, another important factor in this vision centers is like, especially for the chronic diseases from these vision center area, the vision center technician is asked to own them, in the sense to improve compliance for follow-up. If a patient is advised to go refer to the base hospital, it's the responsibility or the ownership of the vision center technician to ensure that the patient actually goes to the base hospital and gets a second opinion on this. And then once they're diagnosed, they're also asked to follow up these patients, whether they are being compliant with their regular follow-ups. So that's something we are trying to ensure that's happening in all the vision centers.
So there's kind of a registry that's maintained.
Yeah.
Oops,
Yeah.
sorry.
Yeah, go
Please
ahead.
go ahead, Usha. Sorry, go ahead.
No, I was just trying to add a point. Like, we have a registry maintained in each of these vision centers, wherein we would have all the chronic diseases registered there. So they have they're in charge of these patients, basically. That's what I.
With all this success, what's been so 20 years later? What's been the view of the government or the other eye care community of the teleophthalmology system based at Aravind? Is the government happy with this, embracing the model and considering a more generalized approach across the country, or is it something that seems too complex and Aravind and places like you could run this, but maybe not generally across the country? Or what's been the kind of the national view of your program?
I think on the whole, very welcoming, both at policy level and at implementation level. In fact, in 2007, now quite in the early days, when we ourselves had very few centers, but then we could demonstrate it's really very effective in terms of providing care to everyone. So one government, which is in the northeast, called as Tripura, you'll have to imagine India wraps around Bangladesh. So it's on the other side of Bangladesh, called a state of Tripura, small state population-wise. So they set up vision centers to cover their entire state, because that particular state had a lot of access issues, largely due to militant kind of law and order situation. People could not move around freely; they had to move in convoys and all that. So that government wanted something which can provide this kind of a secondary, tertiary care to all their citizens. So that was, and we helped set that up. They continue to use our application. We provide some very gross monitoring. And then over time, many other states in the country have embraced it. In the north, like Chhattisgarh state, and more recently, our own state, Tamil Nadu, where we are located. And then crossing borders, Bangladesh has been a big adopter of this technology, both from the non-government sector, like BRAC is probably the world's largest NGO. So they have adopted and established several vision centers following exactly what we do. Same software, same telemedicine application. And then the government of Bangladesh, in fact, just 3 or 4 days back, the Prime Minister declared open another network of 70 vision centers. So altogether, they have 90 vision centers. And when she inaugurated the first 20 about 2 years back, she made a promise that the whole country will be covered with vision centers. And then she is keeping up her promise, and she just declared open 90, and then she has given the budget for another 110. So I think this is kind of taking on both at policy and at local levels. So many small, even private practitioners are now putting up vision centers. Now Rotary has got into this in India. So they just launched a project to establish 200 vision centers. And all of it is being done by non-governmental agencies, private setup and non-government eye care providers.
Kim and Usha, what's your experience of traveling the world and your country, talking about your program? Is there a lot of interest in your communities as well? I mean, folks you interact with?
Kim? You're asking Kim, right?
Yeah. Yes, there has been a lot of interest in this, in the way this is functioning, because I would say this is in healthcare, this seems to be the best last mile connectivity that can create, access to people. So this seems to be becoming a little popular everywhere. And there's been a lot of inquiries are asking us to speak about it in all the forums. Yeah.
Especially after this COVID, I think there's been everybody started realizing the strength of using the technology to our advantage. And I think it's a mutual benefit, both for the patient as well as for the providers.
Well, that's fascinating. I'd like to finish with one last question. It might be the most difficult question, but I think it will gather a lot of interest in the U.S. With the COVID pandemic and in general with the advance of technology, there's been a lot of interest in expanding telehealth in the U.S. But I think that there are a little different settings, some different obstacles in the U.S. that we have to learn about. What would be your advice to kind of U.S. policymakers and doctors and hospitals going forward? Learning from what's happened at Aravind and kind of thinking about the potential in the U.S. I know that's a big question and it'll take us another couple hours to really talk it over, but what kind of principles or kind of key points do you think we should keep in mind as we explore the technology in a broader scale in the U.S.?
Yeah, so definitely, I think there is no part of the world where this is not relevant. And it's quite true in the U.S. context as well, because you also have large communities which are not getting adequate eye care. And we, in fact, did work with one such group in collaboration with Seva Foundation. These were in the Native American settlements. We, in fact, coined a program called as Indians for Indians, for the Native Americans. So in fact, a team did come over from one of the settlements and studied this application, and they found it's very applicable and relevant. And there was some replication done. But then I think you would, more than us, recognize that in the US, one of the major obstacles would be the regulatory framework in terms of, because it has to go through so many validations and things like that before it can be done, and sometimes it becomes a non-starter. So in terms of broad principles as to what can be, how things can be looked at in the US, my kind of very quick thought is that when you are intervening in a patient, it's a spectrum. With some intervention, there is zero room for error. Largely the surgical interventions and things like that, there is zero room for error. And then there are interventions which cause little or no damage. You gave a wrong glass prescription. You can change that. I mean, of course, there is issue of who'll bear the cost. I mean, that's a matter of detail to be sorted out. Or a placebo medication. So putting everything into one bucket, I think you get paralyzed. And typically for all procedures where there is no or low margins of error, will predominantly tend to happen in a hospital setting, whether it's laser injections or surgery, where I think the current laws are adequate to do that. But then 80% of them don't need that. So I think maybe good if the health law in general, the US takes a much more inclusive perspective. I'm not saying about dropping quality. To me, there's a lot of quality issue when you don't do things. And today in the US and in most places, the quality is all about what is being done. If 10 people don't get timely diagnosis because they couldn't be reached, it is not seen as a quality problem. But one wrong diagnosis is seen as a quality problem. Okay. So there is a lot of quality issues in what is not being done. And I think if that change in thinking happens, I think that should kind of moderate, how into the restrictive regulations that are there. Yeah.
Wonderful. Dr. Kim, Dr. Usha, any final comments on seeing your system move across the globe into a country like ours? We could really use your wisdom and advice at this point.
I really hope it can reach out to the US because as Tulsi mentioned, there are definitely areas where the need is there. So
Alan also was talking about this, Alan Robin.
Yes. Alan Robin also is talking about this a lot and how I know there are quite a few people trying to do something like this. We know a friend of ours, Alan Wagner in Virginia, was trying to set up something similar to getting an outreach program started in those certain communities where the access to eye care was not there. So it'll be good if this can reach out to those people who cannot have access to care.
Thank you. Dr. Usha, any final words before we sign off for the morning or time?
I think this is a definite possibility and in all probability will succeed if people put their minds to it. And I think such programs, it's a win-win for both parties. So I think it should succeed wherever it is. I don't think there's any restriction and there's no geographic area which cannot take this up.
Okay. Yeah. Well, thank you all. It's been a real privilege. We're the beneficiaries of your wisdom and counsel, and thank you for taking a few minutes to talk with us here. Nice to see you again. Hope to see you in person sometime soon. Thank you again.
Yeah.
Thanks,
Thank
Mitch.
you.
Yeah.
Thanks
Thank
and good
you.
luck.
Yeah. Bye.
Thank you.
Thank you, Mitch.